I'm Dr. Dan Cox, a professor of counseling psychology at the University of British Columbia, and welcome to Psychotherapy and Applied Psychology, where we explore practical insights with leading experts. Today, I am thrilled to welcome Jill Harkavy-Friedman, the Vice President of Research at the American Foundation for Suicide Prevention. In our conversation, we discuss stigma and suicide, the evolution of suicide prevention research, transitioning into the nonprofit world, gambling and suicide, and much more. Please leave a comment below, and if you enjoy this conversation, it'd be much appreciated if you hit the like button and subscribe to the channel. This episode begins with my guest talking about how she got into studying suicide. Let's jump in.
Actually, my entry into suicide research and clinical work was I was in the right place at the right time, and or maybe the wrong time, because it was 1985, and I got my first job out of graduate school, and my chairperson wanted somebody to study teen suicide and to start a clinic for it. Well, in 1985, you weren't even supposed to say the word suicide, because without understanding it all, the thought was if you say it, you can make somebody suicidal, which, as we know now from all the research, is absolutely the opposite, which is when you talk about it, you can actually help somebody. So he had been trying for a few years, and nobody would do it. And I came along and said, I'll do it. And honestly, that's how I got into the field. At the same time, a high school student who wanted to do a project came to me, and she wanted to look at suicidal ideation behavior in her school. And the principal was concerned about it and also wanted to look at it. So we developed a survey, which is now in existence since 1989, published, in existence longer, and we surveyed her school, thinking maybe we'll get one or two kids who've made an attempt. Well, of 383 people, about 9% of the kids reported that they had made an attempt, and they gave us full details about what they had done, why they had done it, what happened afterwards. And we learned about how it's kind of like the Youth Behavior Risk Survey now. We learned about if they thought about it, did they have a plan, did it stick with them, and it raised the issue of teen suicide in a time where it was just starting to be studied. So it was really the first study that went with data public about suicidal thoughts and behavior in high school students. And then I used those data, and we replicated it 3 years in a row, and was able to get some money from a foundation to start an adolescent depression and suicide program. And that program, when I said I want to call it the Adolescent Depression and Suicide Program, they said, you can't put suicide in the title. I'm just giving you a frame of reference. Yeah. And I said, well, not everybody who's depressed is suicidal, and not everybody who's suicidal is depressed. So how are they going to know where to go? So I'm happy to say the clinic is still in existence and is a training site for psychologists and psychiatrists at Montefiore Medical Center. So
you're
that's
saying
how I got into the field.
So you're saying that because not everybody that that folks who are suicidal, if you didn't have suicide in the name, how are they going to know that this can help?
That's right. That's right.
Okay. So
also not being afraid to say the word, because suicide is more complex than that. But there wasn't a lot of research at the time. And the one study that suggested you shouldn't say it was, if anybody read the study, everybody quoted it, but they didn't actually read the study. And what the study had done is they had interviewed 14 boys who had made a suicide attempt and asked them, do you think people would be uncomfortable if you talked about it? And that's how everybody got to don't talk about it.
Wow. That's fascinating. I didn't realize that. I never really, I don't know, I guess because I'm of an age where it was, I mean, there's still a stigma and that sort of thing, but going to graduate school and, psychology and stuff, it's just, people just talk about it, right? It's not a, but I didn't realize that was sort of where that belief started, I guess.
Yeah, and I used to describe it as I was once at a wedding where the bride made all the women line up, and she turned around and threw the bouquet, and we all stepped back and it fell on the floor. Well, that's what suicide prevention was like. It was really, there wasn't much study of it. There was some biological studies starting in the 70s. And really, though, that research is what led to the development of the American Foundation for Suicide Prevention. Some researchers and some people who lost people to suicide in 1987 got together and said, we need to know more about this, and we need to fund research, because that's the only way we're going to learn about it.
Mm-hmm.
And that is really where the field came from.
I still think about like how many people, how I've no doubt that some reason that there would be more suicide research if there wasn't as much pushback from, you know, places like where I experience it is like from our IRB, from our ethics board. It's like if I have those magic words in there, it's going to be so much more of a pain in the ass to get it through. Like it just is. And it is. And, you know, I mean, you know, I'm well armed, you know, with data to say, you know,
Sure.
this, and I have good collaborators here, you know, David Klonsky, he's been super supportive of me and helping me and getting me stuff through. But like, I wonder about, you know, how much further along we would be in understanding and helping and being beneficial if there wasn't that sort of like, you know, that sort of reaction from the powers that be.
Right. And that's because of, I think, because of a lack of understanding about suicide. You know, suicide is complex. It's not caused by one thing. There are many factors that might increase a person's risk at a particular point in time in the face of maybe some long-term or short-term stressors. And then if you have access to a lethal means, then you could die by suicide. Like, that's a complicated process. It can happen fast in a person at risk, but it's still a complicated process. And people really think if you're thinking about it, then you're at risk. And we know that's not the case. Most people who think about it never act on it. And they may even just have a fleeting thought of it. And even people who make attempts, 90% of them will not die by suicide. So we have to get away from that knee-jerk response. Oh, if someone says they're thinking of it, they're at risk to die, because it's not accurate. And so educating IRBs and people in schools and hospitals about, when you hear that, have a conversation and get to know what the person is thinking, understand what the contributors are, and ask about them. And that's what's got to change. I myself, for AFSP, spend a lot of time presenting at conferences where I stand up and say, with 30% of people with mental health conditions thinking about suicide at some point in their life, excluding people with suicidal behavior means that we end up with treatments that don't work very well.
Mm-hmm.
And if we include them, that's how we are going to learn how to save lives. Imagine if they said, oh, for cancer treatment, well, we can't do this because somebody might die of cancer. Well, of course, you can guarantee that somebody's going to die. Whereas if you look at all the suicide research, it's very rare for it to happen. It happens, but it usually has nothing to do with the study. It has to do with something going on at a person at risk at that point in their life. And so that whole attitude, really, we need to change that. And that's also what's behind developing crisis services now, that not everybody needs to be hospitalized, you know, that most people will get through a period of risk pretty quickly.
Mm-hmm.
Doesn't mean they're never going to be in another period of risk. It just means that most people appreciate when they didn't die by suicide,
Mm-hmm.
and they're glad that they're still alive.
So why don't we get into how did you first get affiliated with AFSP, with the American Foundation for Suicide Prevention?
So I got my first grant from, it was then called the American Suicide Foundation. But we quickly learned you had to put prevention in there. It's a different audience. And I got my first grant from them in 1992 to study suicidal behavior in people with schizophrenia. And I've been working with them ever since. But came on staff July 11th July 10th in 2011. So I've been here since 2011 on staff. But I worked in many projects with them. I was a scientific advisor. And I took the position because, and I still feel that what AFSP does is well-informed, well-intentioned, and effective, or potentially effective. Like, they just do. They may take some time to get it to the public, but we do really sound work. And when we say something, it's coming from a place of caring, but also evidence-based. And so I still love it. I came here, I was 55 years old when I changed jobs from Columbia.
Huh. So I mean, how did that? I'm sort of curious for you personally, because I mean, that's to go into this, into this role as, senior vice president of research. That's a huge transition, right? I mean, that's a very that's a big job. Like, what was that? How was that approached? What was that experience like for you?
Well, they approached me because they knew me and they wanted to change their research. At the time, they had somebody who was sort of half time running the research program. And they really wanted to develop a research program, not just a grants program. Now, I was at Columbia for 21 years before I came here, and Albert Einstein College of Medicine, Montefiore, for 5 before that. So I was deep into my career at that point.
Mhm.
And what I did at Columbia was I worked with two different groups who actually they didn't overlap at all. One was the schizophrenia research group, and one eventually was the suicide research group when they came many years after I was there. And what I've always liked to do is consult to others so they can do their work. So I did have an RO1. I did have a federal grant, but I found that I prefer to support other people's grants. And so I became the head of diagnosis and assessment for one grant and the associate director for the other area. And I was teaching research and methodology. And what I used to call low-level statistics for high-level people for all the T32 fellows in the Department of Psychiatry at Columbia.
What's a T32 fellow?
So a T32 fellowship is as a university or hospital gets a grant to bring a group of fellows in and educate them in their topics. So we had a fellowship on substance use disorder. We had an affective disorder, schizophrenia fellowship, and we had a child fellowship. And so in my work there, they all sat in one room together and taught them research design and methodology. So, so I actually had the research background. I had been in the field for many years, so I knew many of the researchers, been presenting and well published at that point. And so it wasn't that big a leap. The bigger leap was moving from a state hospital where I had to wait for pencils to being in a place where you could have the basics that you needed to do the work you needed to do. And so it seems like a small thing, but when your New York State Psychiatric Institute was a great place. They had so much research going on. But it was a big shift, and it's turned out to be great. I have the opportunity to impact the research, the people who are affected by suicide. I've discovered I love to talk about suicide endlessly and really motivate people and train clinicians. So, like I said, I did not expect to change positions at 55, but it turned out to be great. And it's such a great place. So that's part of why.
So, what's a day in the life of a vice president of research like?
Well, I can only speak for myself, but I think this is that I like it so much because I say I'm a Gemini. Geminis like to do a lot of different things at once. And so, in addition to doing this podcast with you, and you are an AFSP researcher, so I've been able to both not help your application across, but follow your application, advise about research and methodology, and now that you had a grant, then I read every progress report and what you're doing. We share the publications. So when I came here, my goal was to not just have a grants program, but also to have a researcher education program and to educate the public about what we're finding in research. Frankly, it's very nice to give a talk to your peers, but even better is having an impact on people's understanding and behavior about suicide prevention. And so we're in those domains now. So our grants program is very robust. We funded $7.5 million worth of new research last year, 34 new studies. We have webinars for researchers to both career development as well as topical uh, areas, and you can actually go to our website and watch them. Look at the slides are there. We also have been disseminating research through social media and traditional media, and so fun, like having TikToks about suicide prevention. And it's from July to January, we had 4.5 million impressions about what we're learning from suicide research. So my day might be going over a new TikTok, developing a webinar for researchers. Right today, I'm reviewing grant applications, not reviewing, but assigning reviewers. Because I don't have a vote in the actual giving of scores and grants, I get to talk to researchers about their work and advise them about what they want to study. And I get all these calls like, "Do you think I should do this? Do you think I would?" The funny thing is, they say, "What is AFSP interested in?" And I always say, AFSP is interested in preventing suicide and any research that's going to be innovative, potentially impactful, and is methodologically sound. And so I spend a lot of time talking to people applying. We actually give feedback to every applicant if they don't get the grant. And so I also end up speaking to people about their feedback if they don't understand something, for how they can make their grant better, because we allow for up to 2 resubmissions. In the nonprofit world, usually you apply for a grant, you get a yes or a no, and that's it. But our goal is to develop the field and the research community. So I might do that. We might have a call about our upcoming International Summit for Suicide Research that we partner with International Academy for Suicide Research on. I also today did an in-service for our staff on gambling and suicide, an update. So that was this morning. And that's kind of what it's like. Our goal is to prevent suicide, to develop research, advocacy, education, and support for people affected by suicide. And that's what I get to do every day.
So I have to sort of just, there's a lot of things you said, a lot of places we could go, but I feel like you just hit on the gambling and suicide thing. And I know nothing about it, but I was just talking to one of my students who's doing her internship at a VA, and we were talking about it and what she was seeing, sort of boots on the ground. Is it, could you give us just, this maybe a little unfair, but could you give us a thumbnail of, like, big picture, where are we with gambling and suicide?
Yeah. Well, it's like many things in suicide. When you have a gambling disorder, there's not a lot of data, so these are going to be gross generalizations. They're not firm, but it does look like people with gambling disorder have a higher rate of suicide than the general population, more than people with anxiety disorders, depression, mood disorders, less than people with substance disorders, major depression, bipolar disorder, and psychosis, which is what we find with so many things. If you look at eating disorders, it's the same thing. It's the combination of eating disorders with one of those 4, usually mood disorder, substance use, psychosis. Same thing with PTSD. So it's that multi-determined nature, that if a person has other factors, like in addition to a mental health condition, if they have a history of sexual or physical abuse, if they have a chronic health condition, if they have a head injury, other comorbid mental health conditions, then that may increase the potential in the context of stress, like financial difficulties, and which gambling disorders cause financial difficulties, relationship problems, intimate partner problems, work and social problems. So those can precipitate shame and also indebtedness, which makes it hard for somebody to get help. So the bottom line is, a person who has a gambling disorder and other risk factors for suicide may have an increased risk, but it's a sign that you need to have a conversation with them, talk to them, find out how they're doing, and help get them to resources. It doesn't mean, it's not a straight line. but
Right.
it's something to look for. And we have all kinds of guides online, like how to have a real convo and videos. We have the Talk Away the Dark campaign, public service campaign. So we offer many opportunities to learn how to have that conversation and what to do. But it's a way to reach people in a particular group, like people who are struggling with gambling disorders, and help them learn, and there are people who care about them to learn about suicide and suicide prevention.
Yeah, it seems so, like when you sort of sit back and think about it, or maybe when I've sat back and thought about it, really think about, so now with so much sports gambling legalization in the US, that I could be, gambling like crazy on my phone, and my loved ones, they will have no idea, right? Or they think I'm doing
That's
it
right.
just a little bit, but then all of a sudden, right, it just sort of like keeps,
Right.
it's a snowball, and I can go down this rabbit hole, and I'm embarrassed, and there's, right, I mean, I would
Yeah.
be, and
Yeah.
then you could just see how isolating that would be, and just sort of this,
Shame. Yeah. And so,
absolutely.
there are pros to gambling. Obviously, most people who gamble are not going to be at risk for suicide.
Right.
85% of people have. So gambling means gambling, betting, gaming. There has to be that you invest something, like you wager something. There's a risk, and it's really uncontrollable. And then there has to be a prize at the end. That's what makes it gambling. So playing bingo, in your community center for fun is not gambling. Playing bingo for money is gambling. Um, so what there are pros to gambling. It's fun and exciting. It's thrilling. It raises a lot of money in a lot of different industries. It creates 1.8 million jobs. And so there are pros to it, but that's fine for somebody who isn't at risk for gambling disorder. And it's a disorder because it is disruptive and impairing. So there are also cons, mostly the shame, the indebtedness, and all the ancillary problems that come along with that. So sports betting, by the way, just started legally in 2018, and it's in 38 states actively. 48 all told have laws that are coming on the books if they're not already. So it's also true that having a little tiny sentence at the bottom that says if you're having help with gambling, contact is not enough. It's just not enough. We need to raise it to the surface, because even if you have terrible gambling debt, that shouldn't be life threatening.
Hmm.
It should just be debt that you can work your way through.
Yeah. Yeah, it's going to be fascinating to see where this sort of goes over the next several years. But I mean, and also thinking about, if I'm doing sports gambling on my phone or other gambling on my phone, that, like, how that just sort of, again, it's just so easy to do it in isolation, away from everybody, right? And sort of like the pros that you're talking about, which I think is really reasonable, that if I'm doing it on my, one of the pros is that there's this social or communal aspect of it, right? If I go to, bingo, and even if it's, even if I lose money on it, that there's still this other experience that can be valuable, socially adaptive and helpful. But if I'm doing it in isolation, but anyway, I just think that that's great that you all are doing that work and sort of getting out. I don't know about ahead of it, but I don't think there's a way to get ahead of this thing. But anyway,
Well, one of the things we're doing is, so we did the research. We need more research. So we will, if we get innovative, impactful, solid applications, we're likely to fund it. I'll be doing a congressional briefing on the Hill at the end of March about it, and we're going to get the ball rolling, because right now there isn't a lot. So part of our work is to be a catalyst to get things moving in the area of suicide prevention, and to welcome even specific communities and populations into the work of suicide prevention. And also people who've lost someone
right.
to suicide, and gambling was a precipitant.
Mhm.
That opens the door for them.
So, how do you think about AFSP? How do you think about the role of AFSP and sort of maybe the unique role relative to other suicide prevention organizations, like the niche that AFSP sits
Well,
in?
one thing I will say about AFSP, and I don't know if you know this, but we have our Out of the Darkness community
Mhm.
walks. And I believe that has put a face on suicide, so that not only do people who go to the walk feel relief, community, and hope, but it's also changed the conversation. Like, people can't believe you're out walking for suicide prevention. And so that's one thing that I think we've changed the whole conversation just by being public and being available. We also, our research is very unique. We're the largest private funder of suicide prevention research. And honestly, other private funders may fund a couple studies here or there, but it's not their niche. So funding research is really something that sets us apart. Our advocacy arm, we have an advocacy office in DC, and we've started and now implement every year and mental health advocacy days in all states. We're in all 50 states now and Puerto Rico. And so now there are advocacy days in all those states. We also have online advocacy. You can sign up, just go there to our advocacy center, and all you need to do is put your name and address in. And if there's an issue that's coming in front of either state or federal legislature, you'll get an email. You can sign it and send it, or you could write a little part. Of course, I always write something extra in, but sometimes I'm like too busy and I just push send. I have to confess. And we know with legislators, if they hear from people, then they will gather more information. And that's how we got 988. We just, flooded them with requests for 988. So I think our whole advocacy arm is unique in a niche. And then with our programs, we have a general Talk Saves Lives, which is a public education program about suicide and suicide prevention. We have 73 chapters. That's also unique. In communities. So the chapters go and deliver the programs to their communities. And now we have a few adaptations. We have Let's Save Lives, which is suicide prevention for the Black community. And we have Talk Saves Lives for the Latinx community. And we'll grow more programs. We're working with the construction industry. We have an agreement with Bechtel. So we're going to bring it. So I think that capacity to take the evidence, turn it into programs, and then deliver those programs is very unique. And we're a nonprofit. We're not doing it for the money. We're doing it to save lives.
I have to say, just listening to you describe all of this, I'm getting overwhelmed.
It's a lot. That's why our website, when people come to our website, afsp.org, I tell them, come in with your specific question. There's an answer there. But then come back and take a dive into another area, and then dive into another area, and learn about what you can do to help save lives.
Yeah. So how does AFSP, so AFSP has priority areas, right? And there might be a different language that you use. So please feel free to correct me. But how does AFSP, what's that process like for deciding on what those priority areas are and what they're not, right? Because you can't do everything and you have to let go of some things that are important. I was just curious about what that process is like.
Yeah, so there are different priorities in different areas. I mean, overall, we have our core values, which you can read about, and our mission, which is to save lives and bring hope to those affected by suicide. And so, on the grand scale, our priorities are research, education, advocacy, and support for people affected by suicide.
So that's like everything. That's
exactly.
So much.
But in research, we're in the middle of our strategic planning process. So we have a 3-year strategic plan. We're coming to the end of it. It is a big process. Our board members, we survey our chapters and our staff, and our board comes together. And we have a strategic planning committee, and we draft a plan, and then we redraft it. So that's our organizational plan. And when our current plan is on the website, and you can read it. And then there's strategies about how we're going to get there for everything. So that's the sort of grand, what are we going to do at AFSP? And you may know that one of the areas that's been an area of interest for us is also reducing firearm suicides, because that's something that we can actually do. It's actionable. And so we've been working with the firearm owning community on that.
That must be really hard work.
The thing is, it's not as hard when you have a conversation. And people don't, actually, it's pretty unusual for someone to buy a gun to kill themselves. It happens, obviously. But most people don't buy their gun for killing themselves. A lot of people buy it because they think they're going to protect themselves. We know that doesn't really work. But so they don't make the connection between having a gun in a home and increasing the risk in your home for somebody dying by suicide threefold. So part of it is really helping to teach people to understand that there are times that you probably want to take that gun out of the home. Oh, and by the way, the average number of guns is 5 in a home, so it's not that easy. Or at least engage in safe storage. And we try to help people understand that and make those connections. But you asked about priorities, and the research priorities are set by our scientific council. And we set research priorities every 2 years, although we might extend them like we have recently. And we look for areas where there are gaps in the research so that we can stimulate research. That's our goal, to stimulate new research. And so all these top scientists in suicide prevention get together. We talk about what we don't know, and then we set priorities and narrow it down to 2 or 3. So our current priorities are research about or by people from ethnic and racially underrepresented communities, research about communities that have higher rates of suicide than it's expected, like the LGBTQ community, the construction community, foster care, whatever the researcher has identified, and then anything about surviving or survivors of suicide loss, because we want to stimulate research in those areas. However, we'll fund any kind of research. It just means that if a grant in those areas is going against another grant for funding, we would err towards the priority. But truth is, we haven't had that problem. We could fund both. So, but it's really to stimulate new research. And so we've had other topics like alcohol, substance use, and opioids, primary care, firearms, many areas where there wasn't any research, and it's done a great job of stimulating the research community to start studying those areas.
Right. Yeah. I mean, for listeners, my experience has been, whenever you do any of these sort of these adjudications for anything, if there's some priority areas or that sort of thing, it's like on the rubric that say the rubric is worth 50 points, that 5 points are given to how close is this to a priority area. So it sort of like gives you a few extra points if you're really bang on with the priority area, but it doesn't exclude you or anything. It just sort of gives you a little leg up.
If your study is neck and neck with another study.
Oh, is that how you guys do it? So it's really,
Yeah.
it's really like that's after everything is done
Oh,
and all
yeah.
the scoring and all the whatever, then it's basically a tiebreaker.
Right. But because we've stimulated the research, like if you submitted a grant, then we've stimulated that application. And
Absolutely,
if it's a good
right.
application, we want to fund it. And so far, we haven't had to make a choice between that and something else because we've had the money from our walks and our donors to fund research. I mean, it literally comes from people walking or raising money or donors.
Right.
That's it. That's where our money comes from. So
Yeah.
on the flip side, if somebody has a grant from us and they're struggling, I will remind them that people walk for this money.
Right. Right.
And so it is a motivator. And a lot of our researchers end up, we would never ask them to like raise money or anything, but they come to the walks to be a part of the community. We have also a research connection program.
Yeah.
Right? So where you can speak with the community about your work. And I think you've done research connection program. And I don't know what your experience was.
Oh, it's great. I mean, it's so interesting. It's so challenging for those of us who, I'm getting better at it, but I just like you said right at the outset, which is, it's nice to talk to your peers, but it's also great to talk to people in the community or others. And because when you talk to your peers, it's like the amount that you might teach them, that you might influence is relatively small because your baseline, relatively, right? It all varies, but when you get out there in the real world, it's like, it's huge because just like anything, right? We have, you and I know nothing about lots and lots of things and had misunderstandings of lots and lots of things that we do. And so the community doesn't. And so the ability to sort of take people from not just not knowing much, but having very substantial misunderstandings of things and just to try to, erase some of those so you can have, the impact can be great, but it's very intimidating because it's like, because your audience is so varied, right? And it's like,
Yeah.
I want to try to meet these people where they are, but I don't know where they are. So yeah, it's very rewarding.
And researchers often learn from the community what's important or what the real questions are. I'm of the opinion that people can learn if we offer them appropriate opportunities to do so. So if we speak about things in a language that's understandable and not, hyper academic or anything, then most people at some point will be able to understand. Like, I think our audience is, and they want to. So I always come from, I've learned that my 4 words that guide me are compassion, respect, patience, and persistence. And so I find that if I am compassionate towards the audience and I respect their ability to learn and understand, and then I'm just patient and persistent, then the message will get there.
Yeah.
And I find that with everything in life, which is why I go to all these meetings saying you have to include people with suicidal behavior
Yeah.
in your research. That takes a lot of patience and persistence.
Yeah. Well, I think with people in the community, when dealing with suicide, just naturally the question comes up when somebody dies by suicide or even attempts it, right? It's why. And how did this happen? How did I not see this coming? How did I, right? All those questions. And I mean, I'll be, to be honest, when, I've lost people to suicide, it's the exact same thing. Like I still, like, even though I know so much about it, I still have that exact same, but I can, over time and with, talking with people in my circle who do have a lot of knowledge, like I can get some, at least what I think is understanding and some clarity and some closure. But if you don't have, that, you want it. And so, so I think talking to people in the community, even if it's not necessarily about their specific experience, just helping them understand generally what could be going on for folks can be tremendously healing.
Yeah, and there is no there's no specific real answer to why.
Right. Of
You can
course.
kind of learn what led up to it, but what made somebody feel that they had no other options is very hard to understand, because in reality, there's always other options. Um, and so I worked with somebody who had made a very serious suicide once, and we were talking about it, and it was like, yeah, but at the time it made sense. It was a decision, and I said it was a decision made on faulty premises.
Mm.
And a couple months later, he came back to me and he said, "I was thinking about what you said, and it's so true." And I was like, "Oh gosh, what did I say?" But and that's what he said. You said it was a decision based on faulty premises, and that's true. In his case, he had a medical problem that was undiagnosed. So he didn't have any cortisol, and so his brain was not functioning properly anyway. And when he got treatment for his medical condition, he he couldn't understand why he did it, and it turned out he had no cortisol.
Yeah.
So that's why I'm a firm believer in getting a good physical, also perceptual, vision, hearing. Make sure all your everything's in a good place.
Thanks so much for watching. If you enjoyed this conversation, don't forget to like and subscribe, and be sure to check out the second part of this conversation. Until next time.